Welcome back, guys. I am Shuman Bhattacharjee, your host for Global Health Concern, and on behalf of Shomu's Biology, in this part of the Global Health Concern discussion, we'll be talking about leukemia, and more special, we'll be talking about the types of leukemia that are there present, and what are the difference between the different types of leukemia. And majorly, the types of leukemia we'll be talking about is AML and ALL. So we'll be learning what is AML and what is AML. Then we'll be learning what are the function of what are the different aspects of those diseases. I mean symptoms, treatments, and all this stuffs. Okay, so let's begin with a basic overview of leukemia first. Then we'll be talking about the later discussions. Okay, first let's begin about what is leukemia. Now, leukemia is a group of malignant disorders which affect the blood and blood forming tissue of our bone marrow, lymph system, and spleen. Now, what we know is that our blood system is made up with many different blood cells. There are red blood cells, white blood cells. Especially those cells like white blood cells are very, very important of those cells because they fight against infections, many different types of infections. They are part of our immunity or immune system. So if there is any problem or abnormality in the production of those blood cells, it will lead to dangerous effects. Now in leukemia, what we see there is a change in the number of cells that are present normally, as the white blood cells actually more. So we'll be talking about this. So this is a disease for mostly blood forming tissue and blood, and especially the white blood cells of that, right? And as the bloods are formed in the bone marrow of our body, so any problem regarding bone marrow or lymphatic system or spleen, which are again vital organs of for our immune purposes, can lead to leukemia or leukemic situations. It actually occurs in all age groups actually, so no major restriction about age group. It results in the accumulation of dysfunctional cells because of the loss of regulation in the cell division. So in one word, if I'm going to say, this is type of cancer, because again, just like cancer, in this case we'll be seeing the rapid amplification and proliferation of a type of white blood cells. So the amount or the number of white blood cells in our body start to rise, right? And why they are rising? Because there is a loss in the regulation of cell cycle division. Now in each cell there is a regulation of cell division. Now if that regulation is lost, the cell division occurs very rapidly, and that will cause enormous amount of cell present in a particular duration of time. That is called as cancer. So in this sense, leukemia is termed as a liquid cancer or motile cancer, which you can see because it is in the blood. So it is not kind of fixed like a fixed tissue kind of cancer. This is a cancer which is in the liquid state, which is in the blood. So it is simply the increment in the number. And this type of disease is obviously fatal if it remains untreated, and it is obviously progressive, right? That's why it's called cancer. It is a malignant type of situation. Now let's talk about the causes of leukemia and what can be the causes generally. Now actually, you can't say about the causes by taking a single example. So no single causative agent can be found like this way, but most form of a combination of factors. You can't blame one each factor for causing leukemia. Many different factors are involved. For example, if you talk about the different associated factors, you can get examples like chemical agents, certain chemical carcinogens that can cause it. We can look for chemotherapeutic agents. Sometimes chemotherapy or chemotherapeutic drugs can lead to this kind of adverse effect. Viruses are obviously a key player because viruses morph or change the morphology of the cell. Viruses transform normal cells into cancerous cells by taking some important features out of those cells. Radiation can be a huge part of this because certain types of radiation like gamma, x-ray radiation, or UV, mostly UV radiation, because UV radiation can mutate DNA bases inside your body. So due to this DNA mutation, it can cause different adverse effects, including this type of cancerous effect into the cell. Or it can be any kind of immunological deficiencies, because we are talking about the immunological factors or immune system cells. So any kind of immunological deficiency can lead to this type of scenarios. Now let's talk about the types. So here you can see, actually, before going into the discussion of types, uh, first let's talk about a basic view of how this actually happens. Now in all of our body there is a system of blood cell formation, right? That's called the poiesis, or the production of certain blood cells, including red blood cells, white blood cells, platelets, and everything. Now if we consider in the very beginning of our journey from embryo towards an adulthood, we are having an embryonic situation where we are having that stem cells. Now the stem cells that we know, they are having the property of producing any type of cell in our body. So they are kind of totipotent in nature. So one particular stem cell can give rise to many different variety of cells. It can generate a blood cell, it can generate our nerve cell, and it can generate our liver cell, many different variety of cells. So they are kind of totipotent in nature. Now that particular term potent or potency means the potential to generate many different variety of cells. Now then the stem cells are start to differentiate, and as they start to differentiate, they start to form two different types of cells. So those cells are called, multipotent. That means they can produce many variety of cells. Not all the cells, because all cell production unit is called totipotent, but those cells which can generate two or more variety of other cells are called multipotent progenitor cells. Now those progenitor cells, as you can see here in this picture, these are the multipotent progenitor cell. Now those multipotent progenitor cell will further divide. They can produce either myeloid progenitor or lymphoid progenitor type of cells. Now both of these myeloid and lymphoid type of progenitor are also multiple progenitor type of cells. Now from these lymphoid progenitors, they produce certain types of cells like lymphatic system cells, like B cells, T cells, natural killer cells, and so on. These are called committed progenitor, because now they are committed to produce a particular type of cells only, not the other one. For example, this lymphoid progenitor will only produce B cell, T cell, and natural killer cell. On the other hand, this CFU of this myeloid progenitor cells can produce two different variety. Among those two different variety, they can produce erythrocytes, platelets, macrophages, neutrophils, eosinophil, basophil, monocyte, and many different varieties of cells. So this is the differentiation during the development, and this differentiation is very, very important, right? Finally they will produce the mature type of cells. Now this development and formation of blood is a most important part. Now if there is any problem regarding this development process, it will lead to the problem, because for example, the white blood cell means we are having monocyte, we are having neutrophil, eosinophil, basophil, we are having B. So these cells are white blood cells. All of them are white blood cells. Now if there is any reason of during this production any chemical agents, for example different growth factors like epidermal growth factor, like monocyte growth factor, neutrophil growth factor, many different granulocyte growth factor or granulocyte growth stimulating factor, GMCS, granulocyte monocyte growth stimulating factor. So if those factors or those chemical signaling occurs very rapidly with the uncontrollable way, they can lead to the formation of huge amount of white blood cells inside someone's body, because in that case it will go uncontrollable, and due to that uncontrollable cellular growth and division, it leads to the generation of huge amount of white blood cells, right? So for a result of that, we can have this type of problems like leukemia. If we look at the different types of leukemia, so we have already discussed about the previous, and I'm your host Shuman Bhattacharjee. On behalf of Shomu's Biology, we are talking about leukemia, and in this video particularly we'll be talking about the types of leukemia. Leukemia is a liquid cancer that I've termed you, because liquid cancer means it is the multiple proliferation of white blood cells in our body due to loss of control in the cell cycle regulation. Now let's see what are the different types of leukemia in this video. So here you can see leukemia can be divided majorly into two different parts. One is acute leukemia, another one is the chronic leukemia. Acute and chronic. Now if we look at here in the acute leukemia phases, so let's begin. Acute leukemia can be divided also further into two parts like AML or ALL. So we'll be talking about them later. It is having kind of in this acute leukemia, one have excess myeloblast or lymphoblast type of cells. Now these blast cells are type of cells which will generate the final mature cells, right, of myeloid and lymphoid lineage. They also have short clinical course like weeks to months, and this type of leukemia is uh, so these are the two important properties of acute leukemia, that they are having excess amount of myeloblast should have, and short clinical course, so weeks to months kind of a clinical course. But on the other hand, if we talk about the chronic leukemia, in the chronic leukemia can also be divided like CML and CLL. So in this chronic leukemia, this is the type of leukemia where we are having accumulation of mature granulocyte and lymphocytes. Instead of having myeloblast or lymphoblast, we'll be having mature granulocytes and lymphocytes in excess amount in the blood. And second thing is that it is longer in the clinical course, I mean several to many years. That's why it's called chronic type of leukemia. It took a very large time, very long time to cure this kind of conditions. So these are the two major types of leukemia, and based on the integral part of the leukemia, they are further divided. Now in major importance, we'll be talking about acute leukemia more, because for nowadays acute leukemia is much more, the occurrence is more, so we'll be more interested to learn acute leukemia rather than chronic one. So let's talk about the acute leukemia and the division of acute leukemia here. So acute leukemia, there are two different types of acute leukemia, AML and ALL, right? Acute lymphoblastic and acute myeloblastic type of leukemia. So what we know by acute leukemia in these cases? Acute leukemia is a clonal or molecular abnormality, right? It's a clonal or molecular abnormality of not normally hematopoietic blast cells. Hematopoietic means heme means obviously related to white red blood cells or blood, and blast cells mean the previous precursor cells that will give us the mature cells. So due to any kind of uncontrollable cell proliferation, we'll get this acute type of leukemia. It actually very common in adults, like 85% of this acute leukemia in adults are of AML type or acute myeloblastic leukemia type, right? So this acute myeloblastic leukemia is more common in adults than in children, but on the other hand, acute lymphoblastic leukemia is more common in children than adults. So these are the major difference between AML and ALL. Now, so what we can see here about the leukemia, the perfect structure of the and how we can determine between the acute leukemia of myeloblast type or lymphoblast type, it depends on the blast morphology. I mean, blast means here is the structure of the cell, the precursor cell that we are seeing. For example, you can see here the example of a blast cell pretty clearly with this black arrow. You can see in AML, you can find the cytoplasmic granules in the cell, right? And it can easily be seen after staining. The cytoplasm is filled with granules, and you can see the typical structure which is called Auer rods. So it's called Auer rods. So Auer rods are seen there, right? And you can also see more cytoplasmic content. So more cytoplasmic content and cytoplasmic granules are much more common in AML, and it also includes 2 to 5 nucleus together. 2 to 5 nuclei rather, because it's in plural in number. So more nuclear, and it is also having larger part in cytoplasm and filled with cytoplasmic granules. On the other hand, in ALL, you won't see any cytoplasmic granules. So that's the typical presentation to know which one is the presentation of AML or ALL, because we have to diagnose before the treatment that whether the patient is having AML type of leukemia or ALL type of leukemia. If it's having AML type, we can find this our rods, we can find cytoplasmic granules and more than 2 to 5 nuclei. On the other hand, in ALL, we won't find any cytoplasmic granules, and the cytoplasm is very less, and it is also having 1 to 2 nuclei most. Now let's talk about the etiology a little bit. Now in this case, what we know about the simple development, you can see here, we've already talked about that, the different progenitor cells and how they actually start. Now from this different progenitor, the development start to occur, right? And the classification of the cellular appearance can also be determined by two important things. One is from the common myeloid progenitor. This is the CMP, or common myeloid progenitor. We can see from this CMP whatever type of problem will occur in this type of cells, in this myeloid progenitor cells or common myeloid progenitor cells. For example, any kind of cellular regulation is lost in this CMP type of cells. Now during this process, all the further cells that are going to be produced from this CMF are going to be AML type, or myeloid leukemia type, because in that case the leukemia will only be in the myeloid lineage, because it attacks, or there is a problem in the common myeloid progenitor. On the other hand, if there is any problem related with common lymphoid progenitor, or CLP, all of this rest of the cells that are going to be produced from the lymphoid progenitor are going to get the lymphoid leukemia type of disease, right? So that's the very common thing about this process, right? Now, if we summarize the whole classification that we studied, how they are classified, actually they are classified based on how much duration those diseases are actually going to stay, and also the type of effect that they are going to show in the blood. So for example, what we see here, the types of white blood cells actually being determined. So what are they? For example, acute lymphocytic leukemia, or acute lymphatic, what I've said, acute lymphocytic leukemia, which is ALL, acute myelogenous leukemia, or AML. Previously I've talked before the acute lymphoid or myeloid leukemia, but the system is actually acute lymphocytic leukemia is ALL, and acute myelogenous leukemia is AML. Then in the AML part, they are further divided into different types, like non-lymphoblastic leukemia, or ANLL. Then other types like chronic myelogenous leukemia, or CML. Now you know CML we have talked about, because this is the part of chronic type of leukemia, chronic myelogenous leukemia, and also chronic lymphocytic leukemia. So you know, chronic lymphocytic leukemia or lymphatic leukemia, whatever it is, this chronic lymphocytic leukemia is the disease of leukemia, or massive proliferation of the lymphocytic tissue cells, or lymphocytic cells like B lymphocyte, T lymphocyte, and all those type of cells. If there is any problem of cell division between those lymphocytic cells, it will lead to the generation of cancer, blood cancer, a type of, and that is called as chronic lymphocytic leukemia. On the other hand, chronic or acute but lymphocytic type of leukemia. On the other hand, if there is any problem in the myeloid progenitor type of cells, like we have seen, chronic myeloid progenitor, CMP type of cells, it will lead to the generation of acute or chronic myelogenous leukemia, right? Okay guys, welcome to Global Health Concern again. I'm your host Shuman Bhattacharjee. On behalf of Shomu's Biology, we are talking about blood cancer, we are talking about leukemia, or which is simply as the malignant type of disease of your blood cells, or blood propagation or blood production system. So in this case, we'll be talking about mainly about the acute lymphoblastic leukemia, or acute lymphocytic leukemia, whatever a term you give it, lymphoblastic or lymphocytic leukemia. But it is an acute type. That means the duration of medical condition will be from several weeks to months, right? Not more than 1 year most of the time. But there is another type of lymphoblastic leukemia which includes more than 1 year of this kind of symptoms, and that is termed as a chronic lymphoblastic leukemia. So let's talk about acute lymphoblastic leukemia first. So what is acute lymphoblastic leukemia? You know, it is a clonal proliferation and accumulation of blast cells in actually bone marrow and in other organs. So chronic proliferation, and the proliferation is of clonal proliferation. This is a medical term in which the process of how the blood cells are proliferated or producing one to another, right? So the accumulation of all those cells in your bone marrow and other organs can lead to this type of effects. Now you can see this is again it is a molecular abnormality of our blast cells, right? It is due to the result of the failure of differentiation and uncontrolled cell proliferation or cellular division actually, right? And it finally accumulates into the different organs of our body, like bone marrow, and many other organs like spleen and other regions. Due to this, it can create many different types of problems, right? So let's talk about it here. So yeah, so what we know about here is this disorder is mostly originates in single B to T lymphocyte progenitor, because this is lymphoblastic. That means most of the time this disorder is going to happen in the lymphatic cells or lymphocytic cells. So most of the time it is going to occur in the B lymphocyte or T lymphocyte of your body, or the B lymphocyte or T lymphocyte progenitor of our blood cells. And this is also heterogeneous disease with different biological subtypes, so you can't actually say that this is the part, because this is heterogeneous in nature. And this is also having the incidence in adults, like 20% of the incidence in adults are of the acute leukemia type, and rest of them it is found in the child or children. Now the child, and this is kind of the basic statistics calculations about this disease. Now let's talk about the symptoms of acute leukemiasis. It is also termed as acute leukemiasis or something like that, or acute leukemia. So the symptoms of acute leukemia includes bleeding. So actually it is having a classic symptom of three important stages. That's called the classic triad. Triad means three important symptoms all together will be occurred if you're having acute leukemia. One is the bleeding, then the fever and infection, and then the bone and joint pain. So these three things are the typical symptoms for acute leukemia: internal bleeding, infection with high fever, and bone and joint pain. So typical three interactions, that's called the classical triad, will give you as the symptoms of acute leukemia. Along with that, we are having symptoms like hepatomegaly, and also we'll be having splenomegaly. That means the enlargement of spleen and enlargement of liver. Both these cases, hepatomegaly means enlargement of liver, and splenomegaly means enlargement of your spleen. Now then lymph, so every all of these things like CNS involvement is also there. So these are in a turn, everything in a turn is the symptoms of acute leukemiasis. And okay, so let's begin with the different. So it actually starts with mild infection and fever. You can't actually, from the beginning, people can't even understand what's going on there inside, because it begins with high fever and joint pain, which is a kind of symptoms are very common to other types of disease of nowadays, but starts to have internal bleeding. You can feel that. Then finally weakness, muscle ache, and the involvement of your CNS, and you can't get hold on to many cognitive part of the of your daily life and many things. Then finally it ends up with kind of, sometimes it can cause even paralysis in the status. Okay guys, we're talking about leukemia, and especially about acute leukemia. And in this video we'll be talking about the diagnosis of acute leukemia. Diagnosis is very important for all the different diseases that you are seeing, because without the diagnosis you can't even tell what is going on inside the body. I mean, you can't actually get for any medication in your body. So if we talk about this diagnosis for acute leukemia, what kind of diagnosis you can use? Actually, I've listed 6 different types of diagnosis here. First is going to be the blood examination, and the blood examination usually contain with the different scenarios and how to diagnose, because the blood examination will reveal what is going on there inside. Because leukemia is the disorder of your blood, the increment of the number of white blood cells in your blood, either B cell or T cell or any type of granulocytes or other type of cells. Now blood examination can tell you anemia. Type of anemia is a kind of condition that may result. Then thrombocytopenia is a kind of condition that may occur. Then variable leukocyte count, that is the most important part, because the leukocyte count or the white blood cell count of your body will increase tremendously. That's the major point for getting whether you are having leukemia or not. And then the blood morphology and the presence of blast cells in your blood, which is not a common thing, because blast cells are not the mature cells which should be present in your blood circulation system. They should be present in the bone marrow and the other regions where they are produced, and they are the progenitor cells, and they will produce the mature cells, and those mature cells should be present in your blood. But if you find blast cells present in your blood instead of the mature cells, then it is the indication of there is something wrong going on during the maturation and propagation of cells in your body. That can lead to the problem. Second thing you can do is the bone marrow morphology in introductions. We can learn the bone marrow morphology, whether there is a presence of any blast cells in the bone marrow or not, or any kind of suppression of normal hematopoiesis or not. Actually, we can detect whether there is the hematopoiesis, which is poiesis means the production process, hem means it's related to blood. So whether the blood production is occurring properly or not, people can actually measure. Third thing is we can use cytochemical stains. Actually, using those cytochemical stains, we can stain different blood cells, and by staining different blood cells, we can tell that uh, we can say that whether there is any problem, because the typical characteristics of this acute leukemia type like AML or ALL, whether those the typical cells, uh, granulocyte cells are present or not, whether the cells are having what is the cytoplasmic content of the cell, whether there is any granule present in the cytoplasm or not, how many nucleuses are present in those cells. So all these properties are giving us important insight of what is going on inside our blood, because any one of this is not a perfect proof for the leukemia. We need to look for many proofs, two or three different proofs, to finally get the answer, yes, we are having acute leukemia. And what is the type, whether it is AML or ALL, the final thing we need to look it in under the microscope to understand the process. Then immunophenotyping is another thing, but it's kind of costly, because in this case we need to find out what is the immunological phenotype of a certain body, what are the different structures that are present in on the surface of the blood group is very important to help us understanding this process. Cytogenetics is another process to use for the diagnosis, and molecular studies are also related, but this last thing, like cytogenetics, molecular studies, are kind of very advanced process which is research is going on. But most commonly people use those cytochemical stains to stain it and look those blood under the microscope. Then bone marrow morphology introduction can be done via the bone marrow, or CNF fluid understanding can be done. Then blood examination can also be, that's the most important part, the blood examination, and the cytochemical staining processes. So these things will give us the insight of whether we are having leukemia or not, or if we are having leukemia, what is the type of leukemia, it is AML or ALL type. It is very important for us to understand. Welcome back, guys. I'm your host Shuman Bhattacharjee, and we are talking about leukemia. Especially, we are talking about acute lymphoblastic leukemia, or acute lymphocytic leukemia, whatever, or ALL. Now, so if we talk about ALL a little bit more, that is ALL treatment morely about. So before the treatment, we must know what is the risk classification of ALL. That means what are the risks that are associated with ALL. Actually, we can divide into three different parts. What is a standard risk type of ALL? Second one is the high risk type of ALL, where the treatments much we need to increase the amount of treatment, and some other types of therapy must be used. And finally, the very high risk type of ALL, where we need to rely on more than one type of treatment to activate at the same time. So let's talk about each of this stuff differently. So what is the treatment strategy? And actually the treatment strategy of ALL is divided, and it's actually depends on certain things. Now, for example, the treatment strategy depends on majorly four important things in all these cases. For example, the risk qualification. What are the type of risk that we're dealing with? That means, first, let's say a person is having a leukemia. We don't know that. We just get some symptoms. We use the diagnostic measures to understand what is going on inside, and we understand that the person is having ALL type of leukemia. So first, once we understand what is the person's problem, then the second thing is that what is the percentage of risk that are related, standard risk, high risk, or very high risk. So that is the first risk qualification is a very important thing. Depending on the type of risk associated with that person's leukemia, the treatment will vary. Second thing is the immunophenotype of the leukemic cells or leukocytic cells. Now, the immunophenotype means what are the type of lineage of those cells are. For example, if we talk about lymphocytic leukemia, that means B lymphocyte or T lymphocyte. So what are the lineage? Whether they are T cell lineage, or B cell lineage. If it is B cell lineage, so whether it is a early B cell lineage or mature B cell lineage, we need to understand the what is the lineage, because lineage is going to tell us, because what is lineage actually. I'm going to say the lineage is the different organization, I mean different origin of those blood cells from different regions. So from those origin, one thread is start to form, and through that thread new cells start to originate. That is one lineage of all the cells present in the one thread. So T cell lineage is a type of different, their morphology is different, their cytogenetic pattern is little bit different than the B cell lineage cells. Now in the B cell lineage cells, though all of them are coming from lymphoid progenitors, but still there will be variations between them, because the immunomorphology is different, their immunophenotype is different. So that is very very important. We need to assess what lineage we are dealing with, because depending upon the type of lineage, the therapy will vary. Third thing is obviously the age and biological condition of our patient, because age is very very vital. There are certain types of drugs that we can only use at a particular age, not more than that years of age. And obviously in certain situations, if that individual is related with any kind of other clinical problems or other kind of clinical situations like pregnancy for example, we need to be very careful about the treatment. So treatment is not fixed in any cases, not only in for leukemia. Treatment is never fixed for a particular type. You can't actually decide this fixing. So it varies on different scenarios, different types for example. And fourth thing is the goal of the treatment. That means what we actually want using that treatment. That is the final thing that we need to assess. What we want to achieve, whether we want to completely cure it or whether it is not possible to completely cure that. So what we want to do for that reason is important. Whether we want to transform the bone marrow or we need to change the blood accordingly with different weeks. So it depends on many different things. Now let's talk about each of these different therapies that are associated, like remission in there's many different varieties of therapies in ALL, and we'll be talking about two or three major types of such therapies. The first therapy here that we are talking about is okay. So the major important therapy for any kind of acute leukemia, whether it is acute lymphoblastic type or acute myeloblastic type of leukemia, is the remission induction therapy. That means we need to use the remittance or remission in those therapy or in those disease. And actually remission means it is the major aim is to change the blood production of your cell, or to change the blood production habit of your body in such a way so that there is no immature white blood cells or blast cells found no longer in your bone marrow or in the blood. Only the normal bone marrow was developed, start development of normal bone marrow again. And the major process of doing this is adding different therapy, different medications like chemotherapy is a part of that, and many other therapy can be involved. So ultimate goal is that whether due to all this medication, uh, to change the course of the development of blood type or blood cell type, there shouldn't be any other type of abnormal blood cells present in blood or bone marrow. There should be the presence of only normal type of blood cells in the bone marrow and blood, right? And that thing only be achieved by the treatment of chemotherapy and other chemical agents, and that is called the remission induction, right? So what we know here is the first type of therapy that we can use is the anti-neoplastic treatment. Now this anti-neoplastic treatment continues with several drugs like uh, prednisone, vincristine, aspergillase. So these are the major types of drugs: prednisone, vincristine, aspergillase. You don't need to memorize all these names if you are having this, but these are some major drugs that are used for anti-neoplastic kind of treatment. And also cytosine arabinoside can also be used in that case. So you can see these are the cytosine arabinoside, aspergillase, and all this type of drugs, all these chemicals are actually enzymes or certain molecules that are going to interact and interact inside the cell to change the development process. And the CNS profile axis is another thing, because CNS or central nervous system is also related with this type of diseases. So CNS prophylaxis can be used for better prevention or the remission induction process also, using this process, right? Now, in this case of this antineoplastic treatment, I forgot to mention that in antineoplastic treatment we can use the treatment duration kind of 4 to 8 weeks, that is 1 to 2 months, and the number of courses is also 1 to 2. So once to twice for 1 to 2 months the course usually continues. And second one is we have talked the CNS prophylaxis. Third one is that supportive care. Supportive care is certain things that is related with for supporting all those medical treatments. I mean, in this case, small exercises, physiotherapy will be attached, and other types of other many different varieties of treatments. Certain chemotherapy can be added. Certain other simple drugs can be given. Antiviral drugs can be provided for preventing certain infections and certain problems which are associated with this type of scenarios, not directly interacting with the disease. Then we can use treatment of complications. Finally, the different complications that give rise due to the ALL and all these things. Any blood transfusion can be provided there, right? So in a sense, these are the thing. Now you can see here that in the so these are kind of all. So this whatever we discussed till now is the remission induction therapy in ALL. The second thing that we can use is the post remission induction therapy. That means after the remission is already been induced, we can use certain therapies or certain chemicals or treatments, that is called post remission therapy. Now in this post remission therapy, the major important thing is generally it is for the standard risk. Obviously it's for the standard risk type, right? So we know that we need to assess the risk parameters for these things. The risk parameter for AML, like standard, high and very high. So for risk parameters for the standard type of therapy, the post remission therapy, we can use simply as chemotherapy. Different types of chemotherapies can be used. Okay, then we can use here generally the chemotherapy that we use are the maintenance therapy using 6 mercaptopurine, methotrexate. These are the these are the typical names you are going to see, you are going to find more often in TVs and many other places, because they are very much important nowadays. You have seen this name millions of times, because these are the typical drugs that are used for the chemotherapy for the first certain duration and for the maintenance period of the time. 6 mercaptopurine, methotrexate, for 2 to 3 years this process will go on, and certain supportive care should be there present throughout this 2 to 3 years of time span. And then we use the other types of therapy which is not continuous but periodical therapies, which are repeated with different times, like prednisone, vincristine. These are the examples of those drugs that are also used for the treatment of chemotherapy. But these are used as the repeated one or periodically repeated treatment process along with the chemotherapy, which is maintenance type of condition. So all these systems will go on throughout the time, and along with the supportive care should be studied, because when you are taking chemotherapy, many different side effects start to emerge, many different problems except for the leukemia conditions start to arise. So you need to take some other medications for that, or some other type of treatment and therapy for that. Mostly people are relying on therapies in these days, except for the medical type, the other types of therapy if people are going to use. And CNS prophylaxis is always there for any kind of problems. Second thing is that what are the post remission therapy for the high risk ALL? Remission is not the final ending. Our first and primary goal for any kind of leukemia is the remission or the induction of remission. Once the remission is initiated, that is the first thing that our aim. The remission means we will eliminate every abnormal cells from the body, and we will replace it with all the normal types of cells, so that we find the normal cells only in the bone marrow, in other tissues, and in the blood, right? But what happens here, if once we achieve that remission period, then the post remission is important to keep on with that therapy. Suppose you give the remission, you provide the remission therapy, and you just stop, then what will happen after certain days, I mean weeks, and even in 1 to 2 months, what will eventually all the normal cells again start to be converted into the abnormal type. They will be malignant again, and again the scenario will turn back. So after induction of the remission, we also need to use some other post remission therapies. That's why we use those chemotherapies, so that those problems, so that we can maintain the period of remission in a longer duration, like 2 to 3 or 4 years. And after 2 to 3 or 4 years, once we see that yes, everything is fine, our cells are still normal, then we start slowly bring that therapy down, and we more rely on supportive care, we more rely on some other types of therapies to finally control that. But it's not again guaranteed that the scenario won't back again. It can back, so again we need to rely on something else. But in for the high risk type of ALL, some other post remission therapies should be used. Now in this case, what we use that for higher risk, not very so, in this case we can use inters so normally the treatment is used is in this case of intensification process is other drugs like methotrexate, so not methotrexate actually, in this case uh, amsacrine is used, right? Amsacrine is a typical drug that is used, and we can also use as xantrone actually, mitoxantrone. So mitoxantrone, amsacrine, uh, methotrexate is used. Obviously, I forgot to mention that high dose of methotrexate can be used, and high dose of cyclophosphamide can also be used. This methotrexate or cyclophosphamide, these are the drugs that are usually used in the standard type of ALL treatment. But in this type of treatment of the intensification process, we can use, right? Second thing what we can rely on is the hematopoietic stem cell transplantation. Now hematopoietic stem cell, it means poietic means the production type. So hemato obviously means the cells of our blood. So hematopoietic stem cells are those stem cells that are having the ability to develop or produce more blood cells, right? So in this case, if we transplant those hematopoietic stem cells or hematopoietic stem cells which are abnormal, due to the abnormal hematopoietic stem cells, for example, we are having problems, we are having different problems like leukemia. So if we change those problematic hematopoietic stem cells, and we just change it with some other valuable and normal fully functional type of hematopoietic stem cell, it can give us. So this replacement is another part, but this is again depends on many things like age, and obviously like other medical conditions of that person, and many things, because stem cell transplantation and any kind of transplantation is not that easy in the medical history, though we are too much nowadays, we are just growing very fast, but still it's not that much easy. So again, in this case, we need to rely on the high dose therapy and the reduced intensity conditioning in both these cases. Okay, so in a sense, these are the two major type of post-remission therapy that are used for the high risk ALL. Now, for the very high risk ALL, we cannot rely on any one type. What we use the high dose type of therapy, and also we use some allogenic stem cell transplantation. So any kind of allogenic means any kind of stem cells that are related to that. We can transplant again those hematopoietic stem cells or many other types of stem cells after the remission is induced. We need to use vincristine in high dose, we need to use methotrexate in high dose, and cyclophosphamide in very high dose. So we never know what is going to be the result, because medical scenarios and symptoms are different from person to person, from time to time. So you cannot fix something that yes, this is going to be happen, this is going to happen when everything is not fine, but we cannot actually mark those things like that. Those therapies are varied from time to time. Welcome back, friends. Welcome to another video session of Global Health Concern. I'm your host Shuman Bhattacharjee. On behalf of Shomu's Biology, we are talking about leukemia. Now, in this video section completely, we'll be talking about acute myeloblastic leukemia. Acute myeloblastic leukemia is again obviously is a part of acute type of leukemia, which is having a small duration, but the disease is quite difficult. So let's talk about what are the different scenarios of AML. So first, let's talk about what is acute myeloid leukemia. It is actually the clonal expansion of myeloid precursor cells because there are many different precursor cells that are present in our body, which finally produces mature blood cells. Precursor cells like myeloid precursor cells, cells like lymphoid precursor cells. So all these types, myeloid and lymphoid precursor cells, they are present inside our body. So those precursor cells will start divide and differentiate. Now finally, once they divide and differentiate, they finally produce other type of progenitor cells like blast cells. Finally, those blast cells will be further converted into the final cells like B lymphocyte, T lymphocyte, which are the lymphatic type of cells, or they can be converted into other types of cell like granulocytes like monocyte, neutrophil, eosinophil, basophil, and all these types of cells. So depends on what is the progenitor type of cell present in our body, because those progenitor cells are kind of determined, but they can generate variety of cells. They're kind of multi-protein. They're kind of, then finally after the division they will produce certain type of dedicated cell line. They finally give us a typical type of blood cell. Now if there is any problem related to those cells of those progenitor cells, for example any kind of cellular control problem or all these things, can lead to the generation of more number of same type of cells in blood, which eventually is a signal of blood cancer. Simply leukemia is dealing with blood cancer. So let's talk about it much detail here about this process. So what is the epidemiology actually? In this case, epidemiology is not that much related with this. Epidemiology is some statistical facts that we can see the incidence is kind of 2.7 per 1 lakh actually. So it's not very much common to have, and 12.6 per 1 lakh in those over 65 years of age. So 65 years of age and over 65 years of age is age for prone to diseases or having problems with cell regarding problems of blood production problems. That's not the big issue for that reason, because it's kind of disease after 65 years is not that a big deal. So actually the median age for this kind of disease is 65 years of age. And if you talk about the more prevalence of this disease, it is more prevalent in males, right? And also the more prevalent in the European descent, so males in the European country, in those western regions. And if you look at the background, it will be Hispanic or Latino type of background, right? So these are the epidemiological and some statistical facts about this AML disorder. Now, what are the clinical symptoms? So let's talk about the clinical symptoms. And we know that this AML that we previously talked about, the AML is not just like CML, because it opposed to ALL or CLL, it is limited only to the myeloid cell line. That's why it's called myeloid or myeloblastic leukemia. Now, in this case, the clinical symptoms can be varied. Now let's talk about them. The clinical symptoms can be of due to the excessive proliferation of myeloid precursor cells in the bone marrow. Certain symptoms start to arise, right? Because see, this is not nothing but blood cancer that I'm telling, the liquid cancer, because the number of cells in blood start to arise due to the failing in the cell cycle regulation system. Now, as a result of that, many different symptoms. So major symptoms like functional neutropenia. Now, functional neutropenia means it is involved with fever and chills, and this is a typical example of infection. Now, any kind like ALL or AML, the major symptoms are infection, internal bleeding, high fever, and all these things, which will be related. They are called typically the infection triad, right? Because three symptoms will work together along with together. Second thing is the thrombocytopenia, which is nothing but the internal bleeding and brushing. And third symptoms is obviously anemia, which is weakness and fatigue. Anemia is not only the reduction of the red blood cells in your body, reduction of hemoglobin from your body, it's also weakness and fatigue, because if you're having anemia, you're having less red blood cell, you're having less hemoglobin in your blood. That means you're having a less capacity of carrying oxygen in your blood, so you will finally have fatigue and weakness and all these things associated with that, right? So all these things are the clinical symptoms for this disease. And not only that, but other findings are also related, like bone pain, right? Joint pain, excessive joint pain start to occur, and other bone pain start to occur. like sternum or lower sternum pains is very common, right? And infrequent, though the pains is infrequent, but thought to be secondary for this kind of symptoms. Along with this kind of symptoms, you can have that kind of process. And certain physical scenarios can also be seen. So what are the physical scenarios that we usually see in this case? The physical scenario, for example, you can see the physical scenario here is the gingival involvement. That's the typical case here, the gingival involvement that we can see, right? Now especially in the monocytic variants. And what is the monocytic variant? Now these are the different classification of this AML, like classification of AML like M4, M5, M1, M2. We'll be talking about that later. So it's having kind of gingival involvement, that rare hepatosplenomegaly or LAD type of scenario. Hepatomegaly means enlargement of liver, splenomegaly is enlargement of spleen. It can have bone tenderness as an intrinsic part, or retinal hemorrhage can also be a part, so blood coming from the retina and all this part. You problem with seeing or vision. CNS infiltration is another very important cause, which is very much common in M4 and M5 type of classes we'll be seeing later. And skin softening is also one. Soft tissue infiltration is another part. You can see here in this picture soft tissue infiltration. You can see the gingival involvement. So here you can see that it is kind of gum is kind of very much kind of the cells are kind of ruptured, the blood cells kind of ruptured in this gum, so they are kind of rotten like structure. You can see the soft tissue damage or infiltration by this process. So many important problems are associated, like extramedullary disease like myeloid sarcoma can also be caused. It can also have involvement with the lymph nodes that is not shown in this picture, but actually more lymph nodes where it is present in your collar or neck, it's present in your armpit and all those regions, because these are high regions or the regions with high lymph nodes. It's also having involvement of intestine, then ovaries and uterus and all these things along with together, right? So now let's talk about some diagnostic studies about the leukemia, and more about the diagnostic studies of acute myeloblastic leukemia, or acute myeloid type of leukemia, or AML type of leukemia. Now diagnosis is always an integral part of the disease, because without diagnosis you can't go for the treatment, right? So the diagnosis majorly for this AML will be on the blood treatment, or the peripheral blood count. Except for that, you can look for the bone marrow and other parts. So let's look at the, so first is it's actually peripheral blood, which is a major one. Then bone marrow evaluation is also associated with that. Now if we talk about here in the peripheral blood, among the peripheral blood we'll be seeing the different types, right? And what we can see here, to identify the cell subtype, we can actually stain the blood cells using cytogenic stain to look for the morphological or histochemical modifications, and also the immunological and cytogenic modifications of the cells, to finally understand what is going on inside the cell. So what are the diagnosis pattern for the peripheral blood of this diagnosis? We know we need to look for the WBC count, or white blood cell count. The white blood cell count increases dramatically in any kind of leukemia. That's why it is called, massive proliferation of white blood cells. That's called the blood cancer. In this case, it is a variable at diagnosis, like 1 to 100 into 10 to the power 9 per liter. So that's the variance of that, and it can rise along with the time of the leukemia and the duration of the leukemia as it is going on. For acute type, it is kind of constant at a particular rate, but for chronic one, it is just having a graph like the amount of white blood cells rising and falling throughout the time. It also having greater than 20% of blood cells present in the blood. It should be another very important option. And also we can find the Oyer rods. Now these rods are fused primary granules in the myeloblast, that you can see. The example of Oyer rod is given here, where you can see the granules, the primary granules are fused. As a result of that, you can find a giant granule inside. It's not a kind of nucleus, it's a granule, a giant granulomous cell you can find inside this the blood stain. Okay. And finally the RBC, you need to look at the count of RBC. And usually the blood diseases, or this leukemia disease or blood cancer diseases, what we can see, the white blood cells dramatically increases, and the red blood cells dramatically decreases. So this is the normal process for any type of leukemia, acute leukemia or chronic, or the AML type or AL type. These are the symptoms, right? Now for the platelets, for this RBCs, actually they're decreased, and the hemoglobin content is less than 10 gram per deciliter. So this is very dangerous. That's why people often are related with fatigue, and weakness and muscle weakness, and many different stuffs are related together. And and also sometimes NRBCs are present, and also the inclusion reflect the RBC maturation defects. If you look at the inclusion, you can find the RBCs are not properly matured, because proper mature RBCs are having a typical shape and structure, and that structure will vary. It's having that typical structure that you can see in this presentation slide throughout the time, but it is having some problems. And if you look at the platelets, that's already placed here. So platelets can the count of platelets are also decreased, so it is hard for the blood clotting in those situations, and they becomes hypogranular. That means the granule inside the platelets becomes less, and the granules are giant in that sense, and megakaryocyte fragments also are received, or also are found in those platelets part. So these are the typical structures and typical process for diagnosing the peripheral blood, to finally know what is going on. Except for the peripheral blood, we can rely on the bone marrow treatment. But so if you look at the bone marrow diagnosis system, it is simply, you can look at the bone marrow, and it will be hypercellular type. I mean, the cell number are very very high, because the cells, the progenitor cells, the blast cells that are present in the bone marrow. And here you can see the the amount of those cells will start to rise. That's why hypercellular condition can be found. Second thing is the decreased fat content in the bone marrow. That's another related fact through this process to diagnose this scenario. And greater than 20 non-erythroid blast cells are found. Now non-erythroid blast cells means it is not a very good indication, because generally erythroid blast cell means those blast cells will give a rise to erythropoietic cells. So erythroid cells means the cells of red blood cell, right? So generally red blood cell production is more, it is required more in our blood. For that reason, the blast cells present in bone marrow are more for the erythropoietic type. But for this white blood cell type, or the blast type, or you know myeloid type, or lymphoid type, in those type of types, uh, they shouldn't be more than 20 at a time in the blood cell present in the bone marrow, but we find more than 20 there. Then fibrosis start to occur, because the tissues start to have kind of damage and breakdown, and fat accumulation is less. Okay guys, we have just talked about the symptoms and scenarios of AML, or acute myeloid type of or myeloblastic leukemia. Now in this video we'll be talking about the treatment, and this is another video of global health concern with your host Shuman Bhattacharjee. So let us talk about certain treatments that are used for regulating AML type of leukemia. And in any kind of leukemia treatment, the major treatment is of two different types, and the treatment depends on many different variables, like the age of the of the person or the patient, and what is the clinical condition of the patient, what is the risk factor of the patient, and all these things. After assessing of all those things, the first thing for this any kind of leukemia treatment is to go for the remission therapy, or remission therapy. Remission therapy is the process of exclude out all the abnormal cell types from the body, with replace it with new type of cells, normal type or fully functional type of cells inside the body. Now for the remission, once the remission is completed, when the induction of the remission is completed by any kind, like bone marrow transplantation or blood transfusion, once this process is done, then the second process is to maintain that remission. That's called the post remission therapy. So let's talk about each of them. So first is the remission induction, and it is commonly using anthracycline, right? Anthracycline is a type of drugs, or the typical drugs that they use here for the first remission induction process, right? And also they can use the cytarabine, right? So they are slightly different. Drug are used for ALL and AML. For ALL, other drugs are used, we have seen. And after that, the post-remission therapy is continued with the consolidation and maintenance. And there are different therapies are associated with this consolidation and maintenance, because for the maintenance there are maintenance type of chemotherapies are present, and for the consolidation other types of therapies are present. Now in this case of the remission induction therapy, cytarabine is also used, and the cytarabine has ample CNS penetration, so no need for any kind of prophylactic uh, agents or prophylactic chemotax there for this process to go on. Cytarabine itself has a CNS penetration, so it can act there, it can take a hold on both this process altogether. And 60 to 80% of the achieve normally for the patient, 60 to 80% they achieve this complete remission using this cytarabine use. So that's why cytarabine used to be a very good drug for that, for primary remission induction. So 60 to 80% of the success rate is a good success rate for that. And for the post remission, consolidation and maintenance, in the consolidation what we find, sorry, where is it? In the consolidation what we find, it is the longer survival than maintenance, and and typically high dose cytarabines are used in the consolidation. On the other hand, in the maintenance part, we use the continue chemtox. Chemtox is the process, or we can use some other type of chemotherapeutic agent, and usually it continues for 4 to 2 months, and the therapy is repeated monthly completely, right? And we use uh, different types of doses. They depend on what is your scenario, what is the situation of the patient, and all these things. So the consolidation part of the AML treatment, if you look at the consolidation part here, it is the following inclusion of the complete remission. So when we get the complete remission, then only we go for the consolidation, and we simply use 3 to 4 cycles of high dose cytosine arabinoside, or which is HIDAC, which is simply known as HIDAC nowadays. It is actually administered approximately every 5 to 6 weeks, and such 3 to 4 cycles are generally used. And this cytosine arabinoside is also used in the ALL therapy, but usually that is used in ALL therapy again in the consolidation period, going on for the chemotherapeutic stage or chemotherapy stage. Then the bone marrow or peripheral blood system can also be used. Now this bone marrow transplantation is another important, but this depends high degree of risk. I've told you any means of transplantation is dangerous, because tissue grafting and rejection is a very very common part, right? So for that reason why we need to follow on this bone marrow transplantation, which is the last option, but usually rely on the chemicals during the consolidation treatment throughout the time, right? Now if we look at the alternative of the consolidation, right? So on the alternative of the consolidation process, we can simply go for uh, one or more of these following processes, which is called autologous stem cell transplant, which is simply after high dose chemotherapy. So we need to take high dose chemotherapy during the consolidation period, then we use this autologous stem cell transplantation. Or we can look for allogenic bone marrow transplantation, which is also again after high dose of chemotherapy, right? So if we look at the advantages and disadvantages of all these processes, we can find that in the autologous treatment, the advantages of uh, autologous stem cell transplantation is the collection and the subsequent infusion of the patient's stem cells allows the administration of lethal dose of chemotherapy, right? So normally if we not rely on this stem cell transplantation, we need to take a lethal dose of chemotherapy to go against some very high risk scenario of AML. So if we find that AML is kind of not possible to easily treat, and remission is achieved like 60 to 80% or something like that, we can use this process of autologous stem cell transplantation, and it saves us the huge deal of not using lethal chemotherapeutic dose. That's the advantage. And the disadvantage is also there, that is leukemic cells may persist in the marrow, so it may not give you full remission, right? It may present in the marrow or blood or stem cell product, right? And for future purpose, high dose therapy more toxin than the standard consolidation. So we can use this alternative of the consolidation, but any type of alternative consolidation that we're talking about, they are more toxic than the standard type of consolidation treatment using drugs, right? But still, this case people can use, because depend on what is the condition of the disease in the patient. If the disease condition is such that we cannot control it using normal consolidation or standard consolidation, we need to use this alternative one, right? And if we talk about the allogenic bone marrow transplantation, now in allogenic bone marrow transplantation, that's another part. In this case, they're also having advantages and disadvantages processes, right? So in this case of allogenic transplantation, this is also risk adapted approaches are related. Now in this bone marrow transplantation, this is also the advantage is that again we don't need to use certain chemotherapeutic agents which are toxic, but disadvantage is also there, because marrow transplantation is a difficult task. It's a deadly task, because tissue rejection, and also for transplanting a bone marrow, you need to have a donor, you need to match everything with that donor, and finding everything is always a huge deal to control. So in any sense, for consolidation, standard consolidation is the best choice, but if there is no other option, then we shift for this alternate consolidation. Now finally, we can use a risk adapted approach, where we can have a favorable approach, an intermediate approach, or an adverse approach. Now for the favorable approach, that is the conventional chemotherapy followed by the transplant only if relapse occurs. Otherwise we don't need to have any transplantation. Simple conventional chemotherapy will do the trick. That's called the favorable type of AML treatment, right? But for the disease which is slightly of high risk, we need to use some intermediate type of treatment. Now this intermediate type of treatment used to have conventional chemotherapy alone sometimes, or sometimes autologous or allogenic transplant, but depends on what is the degree of risk associated with that disease. It depends on the doctor that are dealing with the situation. And third thing is the adverse scenario, where we don't need to have so much favorable condition. In the adverse scenario, the conventional chemotherapy is not enough. We need to also use some allogenic transplant. Obviously we need to use some transplantation, otherwise we won't uh, make that patient to survive. We won't uh, be able to survive. We won't be able to keep that patient in the perfect track there, right? So for that reason, we need to use allogenic transplant uh, right after the conventional chemotherapy in the adverse type of scenarios, right? So these are the second phase of this AML treatment. The first phase is the induction of remission. Second part is the consolidation period, and third part here, the final part, supportive care, which should be going on throughout the time. And sometimes supportive care usually goes on along with the chemotherapeutic procedure, along with the consolidation period. And supportive care involves in the control of GCSF, or so normally GCSF means granulocyte colony stimulating factor, the chemical agent that should be provided from outside as the granulocyte should proliferate. That platelet transfusion, which is not that much, so because platelet is a small part of your the system of blood cells, so it's not that a big deal. We can use platelet transfusions, then use the transfusion is other thing, transplantation is completely different thing. you know uh, PRBCs, like leukodepleted or irradiated RBCs can be taken there, which are no longer be prone to those kind of disease or condition or damages. Or sometimes you can use prophylactic antibodies like fluconazole, right? Prophylactic antibodies. Now this fluconazole or acyclovir, fluconazole is an antifungal like candidiasis against, or acyclovir can be used, sorry, or acyclovir can be used for the HSV or VHV kind of conditions, right? Now finally, the future therapeutic targets, because we need to develop future therapies against certain dangerous infections and problems. So the future therapeutic targets that we use are surface antigens. Sometimes we simply use surface antigens, like using monoclonal antibodies. We design certain antigens that can be used to treat this kind of scenarios. We can use signal transduction targeting molecule like FLT3, or molecules like methylation, angiogenesis. We amplify angiogenesis. We actually block angiogenesis, not amplify. We block angiogenesis. We use certain signal. We interfere with the signal transduction processes during the cell proliferation of those blood cells, so that the cell proliferation is halted and the massive cell division is blocked, right? Surface antigens, we can coat them in such a way so that cancerous cells will not recognize them, right? And also we can use multi-drug resistance reversing agents. Now this multi-drug resistant reversing agents are certain agents or chemicals which will reverse the scenario. There are certain chemical factors, there are certain triggers, there are certain you know uh, chemotherapy, not chemotherapy, there are certain carcinogenic agents which will have mutation in cell, which will turn normal cell, transform normal cell into the mutated form of cells, or into the cancerous cells. Now if we reverse this, if we can reverse the effect by using some other type of chemicals to have a reverse mutation there, we can get certain important facts, and that is our goal in future. And also gene expression profiling is another important part, very important part. Then we can profile the genetic expression of the cell, of the system. We can do that, then we can use it, right? So in a sense, this is in a whole the future therapeutic targets that we can usually use for the future purposes against AML type of disease, right? So that's it. And okay guys, this is Shuman Bhattacharji on behalf of Shomu's Biology. I welcome all of you for the another session of Global Health Concern, and we are talking about the classification of AML and what are the type of, not only for AML but for any kind of leukemia, majorly of AML here, acute leukemia mainly. So acute leukemia classification are of two different types. One is a FAB classification, another one is the WHO classification. FAB and WHO, they are different organization of health and diseases. They organize and classify different varieties of leukemia. For example, according to FAB, there are many varieties like M0, M1, M2, M3, M4, M5, and up to M7 or 8 different types of leukemia is there. For example, all of this type of leukemia have different form, different full form. They are having different morphological status, the status of specific ester is present in there or not, and all these things. For example, if you look at here for the M1 type of leukemia, it is acute myeloblastic leukemia with no maturation. Sometimes we can have acute myeloblastic leukemia with maturation, which is type 2, which is M2, right? And their properties are provided in this table. I won't at all encourage you to memorize this table, but if you need information, for that reason I put this information here. So you can look at the WHO classification of acute leukemia, slightly different, like different whether the AML which is recurrent with genetic abnormalities, whether AML with multilineage dysplasia, or AML and MDS therapy are related or not. So depends upon so many different things, whether AML is non-otherwise categorized and so on, right? Now certain examples are provided like M1, which is the AML without maturation. So if we look at the AML without maturation, this is the typical example of AML without maturation. We are having the myeloblast with Auer rods. You can see the myeloblast. Auer rod means those cells are having the fusion of many granules inside the cell, and it will form a large granule inside. You can see a very large granule inside the cytoplasm. That's called the Auer rod, and that is the typical example of AML. You can't see this thing for ALL, and this is for without maturation. And the nitrogen to carbon ratio inside the cell is high. That means the protein content is very high, and we are having fine chromatin structure inside, and prominent nucleus can be seen, that you can also see there. For M2 type, it is called the AML with maturation. Now you can see in AML with maturation, we can find certain white blood cells are having multiple nucleuses there, right? So all stages of neutrophil maturation can be found. Greater than 20% of myeloblasts are of this type, and also the attachment of those granules, and big granules are also be seen. M3 type is the promyelotic leukemia. Promyelotic leukemia is also having the phagot cells with bundles of iron rods, and they're also having genetic translocation between the chromosome 15 to chromosome 17. So you can see the typical kind of structure, and hypergranulation can be obtained. Compared to the iron rods, you can see the hypergranulation. Due to the hypergranulation, the cell is filled with granules, and if you put the cytogenic stains, it will get a huge dense color in those granules. You can see here the dense color here. M4 is the acute myelomonocytic leukemia. Now, myelomonocytic leukemia means, monocytic means obviously it's having only one nucleus there. Monoblasts and promonoblasts are seen, and in this case some neutrophil precursors can also be seen in these cases, and vacuolization is often seen. So these are the properties which will distinguish between one type of AML to another type of AML, and this is actually required in the diagnosis section, whether to determine what exact kind of AML type of leukemia is occurring. It's very easy to distinguish between AML or ALL, but it's hard to distinguish between only AML type, because AML are varied, monomyelotic and all these things. M5 is acute monoblastic leukemia. Again, the presence of monoblasts are easily seen. There also you can see iron rods, and you can see the hemophagocytosis. Hemophagocytosis means they start to phagocyte your own red blood cells, your own blood cells. You can see here those monoblastic cells are kind of phagocytic in nature, and they phagocyting their own blood cells. Kind of dangerous scenario. You can see nuclear localization that we can't see actually in these pictures, but in other picture probably we can see this. And this M6 is the acute erythroid leukemia. This acute erythroid leukemia, you can see the striking poik. We don't know what the striking poik means. Actually, the granulation is high, kind of similar pattern. Nuclear lobulization can also be seen here, and high number of RBC precursor are present there, like erythropoietic cells or erythroid cells. So the problems here we can see are the cells of erythroid, not exactly of white blood precursor. They are red blood precursor cells, and the problem or proliferation of red blood precursor cells, remember, is also a type of blood cancer. People sometimes may not link with that. People may not don't know that. You probably may don't know that, but that's the true thing. Number of red blood cell is fine, but if you are having immature red blood cells, if you are having more immature progenitor cells of the red blood cells like erythroid cells, that is another indication of cancer. That's called the erythroid cancer or erythroid leukemia. And you can see greater than 20 number of myeloblasts in this each part, and that's dangerous. M7 is acute megakaryoblast leukemia. Now, megakaryoblast is another type of cell type, and in the peripheral blood you may see the micro megakaryoblast. I mean megakaryoblast, but they are in the small form. Then you can see the fragments of megakaryocyte, and you can also see the dysplastic segmented neutrophils and platelets in the blood. So all these things, these things, this singularly can't give you the idea of what is going on. You need to rely on many more things. You first rely on these things, then for other symptoms correlate with the clinical condition with these studies that we from the peripheral blood analysis as well as the bone marrow analysis, and we can get the answer, right? So for the bone marrow, you can often see the dry tap, very dry, fibrosis start to occur, and fat deposition is less. So these in a sense are the different classification of the different types of AML, and I hope that's helpful, guys. Thank you.